Menstruation is the endometrial cycle that is associated with monthly cyclical production of estrogen and progesterone by the ovaries. This operates through the following stages: proliferation of the uterine endometrium, development of secretory changes in the endometrium, and desquamation of the endometrium, which is known as menstruation. Before going to the detailed discussion of monthly endometrial changes, we should have a basic knowledge on the ovarian hormones, estradiol and progesterone. The estrogen and the progestin are the two types of ovarian sex hormones. The most important estrogen is hormone estradiol and important progestin is progesterone. The estrogens mainly promote proliferation and growth of the specific cells in the body that are responsible for development of most of the secondary sexual characteristics of the female. And the progestins function mainly to prepare the uterus for pregnancy and the breast for lactation. In normal non-pregnant female, estrogen are secreted in significant quantities only by the ovaries. A minute amount is secreted by adrenal cortex, and during pregnancy, large amount of the estrogen are secreted by placenta. Only 3 estrogens are present in significant quantities in plasma of human females. These are beta estradiol, estrone, and estriol. The principal estrogen secreted by the ovaries is beta estradiol. The estrogenic potency of beta estradiol is 12 times that of estrone and 80 times that of estriol. In the non-pregnant female, progesterone is usually secreted in significant amount only during the latter half of each ovarian cycle by corpus luteum. Large amount of progesterone are secreted by the placenta during pregnancy, especially after 4 months of gestation. Estrogen and progesterone have steroid nucleus. They are synthesized in the ovaries mainly from cholesterol derived from blood and to a slight extent from acetyl coenzyme A. During synthesis, mainly progesterone and androgens are synthesized first. Then, during follicular phase of the ovarian cycle, almost all the androgens and the much of the progesterone are converted into estrogen by the enzyme aromatase in the granulosa cells. Because thicker cells lack aromatase, they cannot convert androgen to estrogen. During the luteal phase of the cycle, the rate of production of progesterone is too much that all are not able to be converted into estrogen, which accounts for the large secretion of progesterone into the circulating blood at this time. Both estrogen and progesterone are transported in the blood bound mainly to the plasma albumin and with specific estrogen and progesterone binding globulins. The binding between this hormone and the plasma protein is loose enough that they are rapidly released to the tissues over a period of 30 minutes or so. The liver conjugates the estrogen to form glucuronides and sulfate, and about 1/5 of this conjugate product is excreted in the bile. Most of the remainder is excreted in the urine. Therefore, diminished liver function actually increases the activity of the estrogen in the body, sometimes causing hyperestrenism. Within a few minutes after secretion, almost all the progesterone is degraded to the other steroids that have no progestational effect. The major end product of progesterone degradation is pregnenolone. About 10% of the original progesterone is excreted in the urine in this form. Therefore, one can estimate the rate of progesterone formation in the body from the rate of this excretion. During childhood, the estrogen is secreted in minute quantities, but at the puberty, the secretion increases 20-fold or more under the influence of pituitary gonadotropic hormones. Due to this, the ovaries, fallopian tube, uterus and vagina all increases several times in size, and also the external genitalia enlarge with deposition of fat in the mons pubis and labia majora. Labia minora also enlarge in size. Estrogen changes the vaginal epithelium from cuboidal into stratified type, which is considered more resistant to trauma and infection. Uterine size increases twofold to threefold, and this also causes marked proliferation of the endometrial stroma and greatly increases development of endometrial glands, which will later aid in providing nutrition to the implanted ovum. Just like uterine endometrium, estrogen causes glandular tissues of the fallopian tube lining to proliferate, and also they cause the number of ciliated epithelial cells that line the fallopian tubes to increase. They also increases the number of ciliated epithelial cells. Estrogen causes development of the stromal tissues of the breast, growth of an extensive ductile system, and deposition of the fat in the breast. The lobules and the alveoli of the breast develop to a slight extent under the influence of estrogen alone, but it is progesterone and prolactin that cause the ultimate determinative growth and function of these structures. In summary, the estrogen initiate the growth of breast and of the milk producing apparatus. They are also responsible for characteristic growth and external appearance of the mature female breast. However, they do not complete the job of converting the breast into milk-producing organ. Estrogens inhibit osteoclastic activity in the bones and therefore stimulate the bone growth. At least part of this effect is due to stimulation of osteoprotegerine, which is also called osteoclastogenesis inhibitory factor, a cytokine that inhibits the bone resorption. Estrogen also have potent effect on skeletal growth. They cause uniting of the epiphysis with the shaft of the long bones. This effect of the estrogen in the female is much stronger than similar effect of the testosterone in male. As a result, growth of the females usually ceases several years earlier than growth of the males. Estrogen deficiency leads to increased osteoclastic activity in the bones, decreased bone matrix, and decreased deposition of the bone calcium and phosphate. In severe cases, it may result in osteoporosis and bone fracture. Estrogens cause a slight increase in total body protein, which is evidenced by slight positive nitrogen balance when estrogens are administered. Estrogen increases the whole body metabolic rate slightly, but only about 1/3 as much as increase caused by male sex hormone testosterone. Estrogen also causes deposition of increased quantities of fat in the subcutaneous tissues. In addition to deposition of the fat in the breast and the subcutaneous tissues, estrogen causes deposition of the fat in the buttocks and thigh, which is characteristic of feminine figure. Estrogen do not greatly affect hair distribution. However, hair does develop in pubic region and axilla after puberty. This is due to the androgens formed in increased quantities by the female adrenal glands after puberty. Estrogens cause skin to develop a texture that is soft and usually smooth. These also cause the skin to become more vascular, which is often associated with increased warmth of the skin and also promotes greater bleeding in cut surfaces than is observed in men. A major function of progesterone is to promote secretory changes in the uterine endometrium during latter half of the monthly female sexual cycle, thus preparing the uterus for implantation of the fertilized ovum. Progesterone also decreases the frequency and the intensity of the uterine contraction, thereby helping to prevent expulsion of the implanted ovum. It also promotes increased secretion by the mucosal lining of the fallopian tubes. These secretions are necessary for nutrition of the fertilized dividing ovum as it traverses the fallopian tube before implantation. Progesterone promotes development of the lobule and the alveoli of the breast, causing alveolar cell to proliferate, enlarge and become secretory. However, progesterone do not cause alveoli to secrete milk. Progesterone also causes the breast to swell. Part of this swelling is due to secretory development in the lobule and the alveoli, but part also results from increased fluid in the tissues. Now, coming back to monthly endometrial cycle. Proliferative phase of the endometrial cycle is also known as estrogen phase. This occurs before ovulation. At the beginning of each monthly cycle, most of the endometrium has been desquamated by menstruation. After menstruation, only a thin layer of endometrial stroma remains, and the epithelial cells that are left are those located in remaining deeper portion of the glands and crypts of the endometrium. Under the influence of the estrogen that is secreted in increasing quantity by ovary during the first half of the monthly ovarian cycle, the stromal cells and the epithelial cells proliferate rapidly. The endometrial surface is re-epithelialized within 4 to 7 days after the beginning of the menstruation. Then, during the next week and half before the ovulation occurs, the endometrium increases greatly in thickness, owing to increasing number of stromal cells and to progressive growth of endometrial glands and new blood vessels into the endometrium. At the time of ovulation, the endometrium is 3 to 5 mm in thickness. The endometrial glands, especially those of the cervical region, secrete thin, stringy mucus. The mucus strings actually align themselves along the length of the cervical canal, forming channels that help the sperm to move in proper direction from vagina into the uterus. The secretory phase of the endometrial cycle is also known as progestational phase. This occurs after ovulation. During most of the latter half of the monthly cycle, after ovulation has occurred, progesterone and estrogen together are secreted in large quantities by corpus luteum. The estrogen causes slight additional cellular proliferation in the endometrium during this phase of cycle, whereas progesterone causes marked swelling and secretory development of the endometrium. The glands increases in tortuosity and excess of secretory substances accumulates in the glandular epithelial cells. In addition, the cytoplasm of the stromal cells increases, lipid and glycogen deposits increases greatly in the stromal cells, and the blood supply to the endometrium further increases in proportionate to the developing secretory activity, and the blood vessels become more tortuous. At the peak of the secretory phase, about the 1 week after ovulation, the endometrium has thickness of 5 to 6 mm. The whole purpose of all these endometrial changes to produce a highly secretory endometrium that contains large amount of the stored nutrients to provide appropriate condition for implantation of a fertilized ovum during the latter half of the monthly cycle. Until the time of the ovum implants, the uterine secretion called uterine milk that provides nutrition for the early dividing ovum. The fertilized ovum enter uterine cavity usually 3 to 4 days after ovulation, and implantation occurs 7 to 9 days after ovulation. Between this time, the dividing ovum get nutrition from the uterine secretions. Then once the ovum implants in the endometrium, the trophoblastic cells on the surface of the implanting ovum begins to digest the endometrium and absorb the endometrial stored substances, thus making great quantities of nutrients available to the early implanting embryo. If the ovum is not fertilized, about 2 days before the end of monthly cycle, the corpus luteum in the ovary involutes, and the ovarian hormones, estrogen and progesterone, decreases to low level. Menstruation is caused by reduction of estrogen and progesterone, especially the progesterone, at the end of the cycle. The first effect is decreased stimulation of endometrial cells by these two hormones, followed by rapid involution of the endometrium to about 65% of its previous thickness. Then, during 24 hours preceding the onset of menstruation, the tortuous blood vessels of the endometrium become vasospastic. This may be due to some effects of involution, such as release of vasoconstrictor materials. The vasospasm The decrease in the nutrients to the endometrium and the loss of hormonal stimulation initiate the necrosis of the endometrium, especially of the blood vessels. As a result, blood at first seeps into the vascular layer of the endometrium and the hemorrhagic areas grows rapidly over a period of 24 to 36 hours. Gradually, the necrotic outer layer of the endometrium separates from the uterus, and all the superficial layers of the endometrium have discolomated. The mass of the discolomated tissue and blood in the uterine cavity plus the contractile effect of the prostaglandin or the other substances in the decaying discoamate all acting together initiate uterine contraction that expel the uterine contents. During normal menstruation, approximately 40 ml of blood and additional 35 ml of serous fluid are lost. The menstrual blood is normally non-clotting because the fibrinolysin is released along with the necrotic endometrial material. If excessive bleeding occurs from the uterine surface, the quantity of fibrinolysin may not be sufficient to prevent clotting. The presence of clots during menstruation is often clinical evidence of uterine disease. The bleeding usually stops within 4 to 7 days after menstruation starts. This is because by this time the endometrium has become reepithelialized. During menstruation, large number of leukocytes are released along with necrotic material and blood. A substance liberated by endometrial necrosis likely causes this outflow of leukocytes. As a result of these leukocytes and possibly other factors, the uterus is highly resistant to infection during the menstruation, even though the endometrial surface are denuded.